Hey guys, thank you for checking us out on Tactical Scrubs today. I am so excited to have my good friend and colleague David Corbin. I initially met him because I read his book, so you guys should all check out his book on Amazon. I'll definitely put the link there in the show notes. But go ahead, tell us about kind of where you've been, who you are, and what you're doing. And I'm sure we'll talk about some topics and just some experience and how you maybe start and how you got into healthcare security, like maybe what your
Sure.
background is and why you made that transition.
Yeah. So, first of all, thanks for having me. Thanks for the invitation. And yeah, I kind of fell into healthcare security. I started my security career in retail loss prevention, believe it or not.
Okay.
And I started kind of getting bored with it. So I went to my one of my security professor at Northeastern, and I said, "Hey, I'm kind of bored with this. What other options are there out there?" And he introduced me to this guy who worked for a contract security company that did security at Brigham Women's Hospital in Boston.
My one of
And
my
they said,
favorites.
yeah. And he said, they're hiring for an investigator. I'm like, geez, what does an investigator or a hospital do? And I ended up getting the job. Somehow I convinced them, like, with no healthcare experience, I'd make a good investigator. They took a chance on me. So I did that for a while, and I learned very quickly all the things you get to do as an investigator in healthcare. And then all my friends would ask me, what do you have to investigate there? I'm like, you have no idea, and I can't even tell you.
Right.
So that's how I got into it. And then I found myself feeling like I keep investigating things after they've happened. I feel like I could make a better impact if I was on the operations side. So then I
Wow.
became the lieutenant overseeing the 3 to 11 shift, which was the busiest shift, about 30
That's a
officers on
crazy
duty.
shift. Let's just talk about that for a minute. So 3 to 11. So we've
Yeah.
got a set of nurses and healthcare workers that are coming off exhausted.
Yep.
And then you've got people coming in. The
Hmm.
physicians have usually left for the day. Admin
Oh yeah.
people are leaving for the day.
Yep.
Like there is a specific time period there where chaos ensues.
Yep.
Everybody's sundowning at 6, 7, 8 o'clock. So grandma's getting yuppie there naked in the
Oh yeah.
hallway.
Yep.
So that is a really interesting shift to start on. I'm sure that you really got a ton of experience.
Yeah. And trial by fire. It was some crazy stories, but I'm convinced. Well, first of all, that the other thing that I was going to add to what you were just saying as to what happens on the evening shift, at that change of shift, all the meds kind of start wearing off that were given to the patients at the beginning of the day. Like, you can almost see, if you look at the statistics, that at a certain time it's almost like somebody flips a switch and tells everybody, okay, it's like a free for all now, because there's so many, there's a handoff happening, there's the meds are wearing off, and everybody is just kind of like on edge. Um,
What do
so
you
yeah.
think was if you could share obviously like what do you think was the moment where you realized in healthcare security like this is a lot different than what I thought. Like coming from retail over into that
Yeah.
space, like do you remember a distinct moment or you just remember the amount of things that you were having to investigate or having to deal with then when you went to operations that led you to believe like, wow, this is a different industry and
Yeah.
things need to change because I feel like you've been really pivotal in trying to help navigate the industry to like moving towards more of that prevention side.
Right. Right. Yeah, I think that, I realized very early on how big the operation was, because, in retail loss prevention, there was only like two of us on at a time, and, there wasn't much other support. It was pretty basic level security. And then I saw the complexities of healthcare security. You're not dealing with people stealing things, right? You're dealing with people who are there not because they want to be, because they have to be, and you're dealing with a range of emotional issues and psychiatric issues and everything else. So the complexity of it was pretty evident at the beginning. And interestingly enough, when I first started in healthcare, the biggest concern that we had at the Brigham was theft, which, if you look back now, you'd say like, huh, right? Theft,
Yeah.
is that the big? But it honestly, in healthcare at the time, like, workplace violence didn't have the same, not that it wasn't happening, it just didn't have the same spotlight on it. And it wasn't like this hot issue, so to speak. Not that didn't need, it needed attention. People needed to be trained. It was a problem, but it just hadn't risen to the top. So a lot of what I
I
did was
think there
theft
was
investigations.
there was a lot less instances, not because of the people a lot of times want to place blame on the patients and the family
Yeah.
members and, oh, because of COVID, they were cooped up. And that's not really, I don't think what's happening looking at the statistics. I think there is
Yeah.
some contributing factors to that. But I think what's happening is because there's so many unexperienced clinicians,
Yeah.
patients are, some of these patients now are professional patients. I mean, they have been in
Oh
the
yeah.
system, they know the system.
Yeah.
So they know when these new kind of novice nurses are out there, they know what they can manipulate or get away with, or
Oh yeah.
try to, even some of them are trying their best to be encouraging, like, no, I'm supposed to have this at this time. And I think a
Oh yeah.
lot of the problem is coming from the lack of authority figure from the nurse and from the clinician, from these doctors that look very young. And I think
Yeah.
that's part of where me as a clinician, I can help support the security side by trying to educate and train clinicians in a different way. Like, how
Yeah.
do we use our nursing processes and the things that we do professionally to enhance our ability to be seen as an authority figure? So when I say, Mrs. Jones, it's time to take your medicine, you're not arguing with me and we're not
Right.
going into this emotional place because you trust me. And I think
Right.
that is really the change that we've seen. So I could see how back then the focus was more on theft or things that weren't as apparent as the violence is today. So
Yeah.
you realize that theft is happening. You're doing your best to mitigate that. What are the other things that you kind of helped you promote your career or helped you continue on?
Yeah. So I would say that the working the 3 to 11 shift, being in on that very busy shift, it was trial by fire. I realized how much I didn't know about healthcare security at that moment. And it was like kind of like it was still the Wild West days of healthcare security. Very, very little training. Like we didn't have any de-escalation training at the time. It was contract security. Very, no training, nothing. I started to introduce Moab training while I was there because I went and
Mm,
got certified. Not even as like the full instructor. I'd only got like the first level or whatever. That's all I was
right.
allowed to do. And then I brought it to the security team. So it was Wild West, but it was definitely a learning experience, and that's where I really felt was a pivotal moment for me because that got me to the operations side of things and allowed me to have a better grasp on the inner workings of the hospital healthcare and everything else. And a lot of it was just learning, building the plane while you were flying it. But
Right.
that
I think
allowed me to really pivot into a manager role down the line, and then to a director role, which again, I didn't know what I didn't know. Like I literally, when I got promoted to my first director role, like after I got the job, I'm like, I better buy like a book or something to figure out what I'm supposed to be doing. I
you're like,
literally bought a book
oh, does anybody know
on
what
like
the
healthcare security. I'm like, okay, here's what I'm supposed to know.
I feel like that's where the for me anyway, the IAHSS, I was just got off a call with Laura Smith from the UK. And
She's great.
so over there they have a whole entire psych, like nurses become whatever type of nurse they want to become in school. So
Yeah,
she's very expert in those areas. And
she is.
we're
Yeah,
working on writing this textbook. So we're putting out this textbook for nursing students and medical students so that they'll be prepared when they get in. And my goal is to help them actually transition the information to security faster,
yeah,
with better quality, so that if they roll up to a violent event and it's a new security officer and a new nurse, they still are communicating the same way because they're talking the
smart.
same language.
Yeah,
So I talked to her and she was saying that that was like a significant issue everywhere, is that,
yeah,
who's getting the training, where is it coming from? And that's the benefit that we've had with the IAHSS. And a lot of
huge.
nurses that I've talked to, even to kind of very famous nurses I talked to yesterday, had no idea what the IAHSS was. And I was like, and that's not really the fault of the IAHSS. I
Yeah,
think it's just clinical's very siloed. And I think that we're now seeing that there has to be a strong collaboration between the two. And I think that experts like you guys who were in security when it was being developed can really help us drive the protocols and procedures that need to be in place in the minimum when you are building out that type of program.
Agree.
Yes.
Yeah, it's yeah, just really, you mentioned the clinical and security piece, and you probably know Melissa Jones in at Inova. She's doing some great stuff as the director. I think her role is director of workplace violence prevention.
Right.
But she's approaching it from the clinical side, and one of the things she told me that I thought was interesting is like one of the ways that they've actually helped reduce violence against security officers was really just stepping in and making sure that security was being used in the right way. Because again, going back to the early days of
Yes.
my career, it was you call security when you want physical
Right.
intervention, right? You don't even if security came and said, "Hey, let's talk them down," they're like, "No, no, no, we've already tried that. You go in and put them in
And I'll go over
restraints,
here
or
and pass meds." I'm like, bye.
yeah, I'm gonna go to a safe place. I've really worked this patient up. They're really angry. Go ahead in there, and I'll be over here. Let me know when you're done." Like they would just leave. They would leave the room. There's no
Nurses
clinicians in
need
the
to
room.
stop ghosting y'all. We ghost. And it's
Yeah,
because
bye. Yeah,
it's not really because we in our defense, it's because we also have so many other tasks with other patients.
of
It's like,
course.
okay, someone's here, someone's taking care of this. I need to move on. I don't think it's necessarily, and that's where I think the pre-planning is really important. I'm seeing a lot of
Yeah.
these BERT teams respond. They come and they
Hmm.
all congregate in the hallway, and then we're all just standing around looking at the patient, waiting for someone to take over. But
Yeah.
that's not really the point of a BERT team. The point is so that we can pass information quickly and everyone can come up with a coordinated response. But the time to do that is not while the patient's actively violent. The time to do that is before, and approach it with a standard operating procedure.
Yeah.
And the nurse needs to be trained, no matter if they're a contract nurse or first day on the job, they have to have some kind of training on how to say, these were the behavioral anomalies that I identified. This is why I called you. Now, this is what I need to do. And I think, that type of information passing is really important, and it's something that we need to get better at in healthcare. And when I was reading your book, a lot of the things that I really enjoyed were the actionable items that are in the book.
Right.
I get really frustrated when you get this clickbait link, oh, 10, things you can do to help reduce violence. And it's like nothing. Like it's like
Yeah.
that didn't tell me anything. Like you're just
I hate
restating
that. Yeah.
statistics, and
Yeah.
then you're copying something else that somebody else wrote. You're talking about a zero tolerance policy, which is pretty much non-existent, which is something
Can't
we
do
can
that.
talk about because I know that's a conversation that we all have had. I actually got a call from someone the other day, and they were like, "What do you think about a zero tolerance policy?" And I said, it's ridiculous. He's like, I thought the same thing, but the administration's like, you have to do it because the hospital next door did it. I'm like,
It
well,
sounds good.
yeah, it's if patients weren't humans, like they're not robots, and I'm not a robot. So the
Yeah.
concept of us not having emotions is not possible. So and I think if security directors step up and say, sure, we'll do a zero tolerance policy to meet whatever requests that the C-suite is pushing down to them, they now create more distance and distrust between the staff because you cannot guarantee that. So you have a policy, you have signs on the wall, and then the staff aren't seeing that actually happen because it's impossible. And now we've created an even greater divide between security. I discourage nurses all the time from, oh, security, they're just like Paul Bart mall cop. They're not. Like they really aren't now. They are
Right.
professionals and they do have extra training. And a lot of the young guys are really wanting to get into the industry and really elevate. I loved at the Houston chapter meeting, I was able to talk to several young folks that were my age that were new security officers or new
That's
security
great.
directors. And they were very excited about the profession and the potential. And some of them have master's degrees.
Yeah. Yeah.
um, you guys have an excellent skill set that needs to be shared. So maybe talk about a little bit, why did you decide to write the book in the first place?
Um, I just felt like, well, kind of going back to what you said, Mel, is like there's there's two things that make me nuts. Well, there's a lot of things that make me nuts, but there's two things that make me nuts about
You
health
work in
violence.
healthcare, so that's the
Healthcare
first
violence, right?
contributing
My
factor.
default is, yeah, my baseline is kind of, you know where it is. Anyways, um, but like seeing all these things. So there's so many articles about here's all the terrible things that are happening. Here's all the terrible things. Here's the terrible stats. And then you look for the solutions and they're all over the place. And a lot of my clients come to me and say, what are the best practices? It's like, well, it depends on your situation. And
Yes.
best practices, first of all, doesn't mean that it works, right? Second of all, um, it doesn't mean that it's the right fit for you and your resources and your culture and your vision and your mission and everything else and the types of patients that you see, right? So everybody wants to know, are we doing the things that everybody else is doing? But that doesn't mean that it's the right thing. So
Right.
what I was trying to do with this book was to make it first of all accessible to anybody from a line security officer to a clinician to all the way up to the top of the organization.
You did a great job with that.
Thank
I
you.
think you did an excellent job with that. Mission completed, because I
Yeah.
know nothing and I read it and took a lot of value from it.
Yeah, and I tried to make it. I did a lot of research so that it would be evidence based, right? Because I could have come out and say, here's what you need to do, right, and lay it all out. Now, some folks might look at that and say, oh yeah, this is good, but other folks like you and people who are going to ask more questions are going to say, well, based on what? How do you know that that works, right? So I tried to find things that worked, and one of the sources of sort of inspiration was from Brigham and Women's Hospital. There was Barbara Kados over there and some of the other folks worked on a research study about the safe response program that they put in. Now, when I got over there, they had just rolled it out on the inpatient side and they were starting to roll it out on the ambulatory side. But safe response is kind of like a BERT team light version, right? But the whole point is it gets the right resources to you to formulate a plan, oftentimes before something happens, which is great.
Yeah.
Sometimes it happens after, right? The funny thing is that security would always, be part of it. And we'd always get a ton of calls right before the weekend because people were like, let's set up a good plan for this patient for the weekend. But I thought it was a great idea,
That's
right?
a great thing.
We know we have a problem. We know there's not a lot of resources around, right? Let's make a plan before the end of the day on Friday so that we don't leave the weekend folks in a lurch,
As
which
a
I thought was
nurse
great. I always thought
manager,
it was funny. They would always
as
happen on the
an
weekend.
as a nurse manager, I would 1000% rather sit through a meeting till 6
Yeah.
p.m. on Friday
Yeah.
than have to come in at 3 a.m. Saturday morning, because something bad happened. And
Yeah.
I think that's really prudent. And I think when I was out there looking for research, 3 years ago, I started this journey. I pivoted my company to address workplace violence. And I take this very learner mindset. I do not want to be the smartest person in the room,
Yeah.
because then I'm not learning and I'm not helping anybody,
Right.
And I found that there wasn't a lot of research out there. And that's one of the things that I'm excited about being with the IAHSS and being able to have the opportunities to publish or produce articles or write white papers, because
Right.
there are a lot of brilliant people like the folks at the Brigham that do have access and are doing the data collection
Yeah.
that is necessary. And that's what needs to get out. And I think your book allows people to say, here are the things that we're doing well, and these are things that maybe we need to look into, and then to bring on an expert. I tell people all the time, for as far as training goes, because that's really where I live, right, is that
Mhm.
bedside training.
Right.
But I have to understand how it all correlates to the other portions of the organization.
Right.
And those are the things that I say. They tell me, well, you can't have a standard approach to workplace violence. And I'm like, no, you can't when you're looking at full operations. That's why you call someone like David Corbin, to come in
Mhm.
and give you advice. But we can always have a standard response to the
Right.
actual violence that's occurring, because it's just like when a patient dies, you go in the room, they have no pulse. You're going to
Right.
start CPR, you're going to push the code button. And then some hospitals even have roles already assigned for when people respond. And that's
Uh-huh.
ideally what our training is like. It's CPR. And
Yeah.
then you have the option to build on it with other collaborating folks. If you want to do a threat assessment, you want to have more collaborative approach to the different areas that need help. But
Right.
we can't just, because we don't have the perfect solution, leave the people out that are getting assaulted every day.
Yep.
I spoke to, I don't know if you saw the article yesterday that was published from the Washington Nurses Association about Seattle Children's Hospital.
No.
And there's a behavioral health unit there with like 44 nurses. And they had all the incidents listed. I guess the nurses reached out to the nursing association.
Uh-huh.
So I spent all day trying to figure out who to call. I got someone on the phone, and she was like, as a nurse, I'm appalled that you think that these nurses need more training. They need legislation. And I was like, okay, well, legislation is a piece of paper and it's a late action item. And I'm really
Yep.
happy that you're in the space trying to advocate for it. But like, what about the nurses that are working right now while you and I are having a conversation? Like,
Right.
everything I read in those incidents is preventable with the
Mm-hmm.
appropriate amount of training. She's like, well, this is a systems issue and it's problems. They're holding patients in the ED. And I was like, this is a problem that's happening at every hospital in the world
Right.
right now. So
Oh
you're
yeah.
not telling me anything new that I haven't thought about. I
Right.
was like, the point is that the workers, whether it's healthcare security, the nurses, the CNAs, whatever, they need at least the tools to keep themselves safe. I understand these are pediatric patients, but they still
Right.
deserve the same care and compassion. So does the staff in dealing with them, and
Of
I
course.
think just the narrative around it and hearing how like one against the other, it was, this is
Yeah.
your problem. No, it's your problem. And it's not. And ultimately, it all comes down to the same thing: securities and concentric layering. If you
Mm-hmm.
don't, fortify your perimeters, your access points, then you move in. I mean, there's ultimately, you have to still provide the healthcare worker or the people that are providing care with the tools to know, is it a no-go or a go situation, and how
Right.
do I mitigate in between? So your book, I think, really focuses on moving through those concentric layers, and
Right.
how do you put the things in place at each level at a very high view. I think it was a
Yeah.
great synopsis of what you can do actually in a tangible way in your organization to make a difference.
Thank you. Yeah, and I focused on work patient generated violence because when I started out, I'm like, oh, I'll write it on workplace violence, but it's such a huge topic, right? Like we were chatting back and forth on LinkedIn today about lateral violence, right? I could
Yeah.
have written a whole section on that. It could have been a whole section on, outsider or targeted violence, like all these different layers. And if you pick that book up, you'd be like, where do I start, right? Because,
Right.
but with patient violence, if you build that program, and I'm not saying like you have to follow every step exactly that same way. It's meant to give you the structure, right? The framework. But if you build it using that framework, then you can add those other pieces on, and they'll still work with that framework, right? It's not like you need one framework for patient violence, one framework for lateral violence, one framework for outside visitor violence, whatever. It can all work together, but
Correct.
patient violence is the most critical type of violence that we're dealing with. Is that that's what's on fire, and that's what's going to remain the focal point, right? So if you can impact that violence in a positive way, then you can start focusing. Not that you shouldn't be focusing on these other areas, but that's where you're going to get the most bang for your buck, right? If you focus your efforts there, you're going to drive down staff injuries, you're going to drive down the trauma, turnover, all your exposure points to liability and fines and everything else that comes along with that, right? But that's really what the idea was, right? Because if you can take it in chunks, and I purposely wrote the book in a very concise way, because I knew if I published something that was 400 pages that nobody would ever read, I wouldn't read it, right?
Right.
I mean,
Right.
the field manuals that I used, the Army field manuals that I used to like give me a sense of structure as to how I should structure it and how like the wording should be, and it's very basic level wording. Those things are like this thick, and I'm sure if you're training to be whatever, military police or whatever you're training to do, yeah, you're gonna have to read that book at some point, right? But I don't if I'm somebody looking to figure out how to jumpstart my patient violence program, I do not want to go through 400 pages,
You don't
and
have the
it needs to
time
be
because
quick and concise.
probably
Yeah,
if you're a security director, you're in charge of what, parking, you're in charge of visitor management, you're in
yeah,
charge of your entire workforce, then you're looking at every violent incident with risk management, you're
yep,
looking at everything, loss and theft. I mean, you're in charge of all of that. You don't have the time. And the same goes with on the clinical side. If you're a CNO and you're now told, oh, we have to develop a workplace violence program, you're trying to run the entire clinical
of course.
operation in addition to doing that. I think that's where having a pool of experts is really important.
Yeah,
You know, for me as a network, you know, I could pick up the phone and call you and be like, hey, what do you think about this? And we can have a quick conversation and then go
right.
back to the client and be like, look, I really think David is a good fit for you. Or you probably don't need David right now because you've got a really strong security director, but
Hmm.
let's look at a portion of the program that you need support. And I think that, you know, the cost of losing one nurse is around 50K, and the cost of
Yeah,
losing a physician is between 1 and 2 million. So I know a lot of my friends and collaborators, the cost of their services come well under that, you know, or close
yeah,
to that cost of losing just one nurse. So if you can, and that's why we made our training so cost effective. So we can train an entire facility for 25K.
yeah,
And the reason that we can do that is because we use anybody who's already teaching CPR and ACLS.
yeah,
So because they're already doing it. The idea that nurses need some like RoboCop to come in and like teach them how to be John Wick is not practical. Like, first of all, pain response in somebody who's a substance abuse issue or psych patient, they're like, snap my finger, I'm Jesus. And you just proved to me that everybody in here is out to get me, you know? So like
um,
that does not work. So we have
yeah,
to have a
yeah,
different approach. Plus, I'm 4'11". Nothing that I say to a 6'5", you know, felon is gonna matter. He's gonna be like, I'm gonna choke you whether I want you, whether they tell me not to or not. And so the approach has to be different when you're dealing with clinical, but still giving them the skill set that they need to protect themselves and the patient. And I think that's one of the benefits of having a professional like yourself, at least in the mix when you're challenged to build out a workplace violence program. Tell us a
yeah.
little bit about how your consulting works. Because, like, for me, get a phone call. We either have a rapid response team that goes out that trains immediately for the thing that just happened, right? Because that's how we are
Yeah,
reactionary
smart.
in healthcare.
Yeah, I like it.
Or you bring us in and we train in the beginning, and then we hopefully avoid and watch the metrics to help reduce the violence. But tell us a little bit about how you consult.
So, I mean, most of my clients are looking for well, most of them are looking for a workplace violence focused engagement. Some of them want me to look at just the workplace violence program, meaning everything from training to, even the physical security measures that they've implemented and electronic security measures. Um, and a lot of my clients want me to do like a full scale security risk assessment, meaning everything from physical security, electronic security, to the security department and their operations. How are they being trained? What are their policies and procedures? Looking at security related emergency procedures and preparedness. So like really the whole soup to nuts kind of thing, where I'm looking at all of their security program and their violence prevention and mitigation program. Um,
How long does something like that take you, or is it dependent upon like how big they are and
yeah,
what they have?
depends on the size and the scope. I've done very large organizations that have, more than 450 sites, which, by the way, I don't visit all the sites because I would never finish. But, you know, I would, for a larger scale one, it can take from the time that the engagement starts until like a report is issued, can take like 60 days or more, depending.
That's really good though. That's
It's not,
really
yeah,
good.
it's not bad. I mean, it
To
depends
me,
on,
as a former DON, like
yeah,
that is a really good turnaround time for
yeah,
knowing all of the things that you would have to look at. That's shocking to me.
yeah. And along the way, obviously, if I find something that is needs to be addressed urgently, like I will tell somebody, like when I find it, right? If whoever my point of contact is, I'll say, hey, I just found XYZ. I would advise you to address this right away. Or somebody who just told me about an incident they haven't reported, you need to, talk to this person. So I don't wait for the report to come out. By the way, there's a really critical issue that, I
By the
identified two
way,
months ago.
6 months ago. No.
Well, yeah, I wanted to put it in a report. So 60 days is a typical turnaround, but part of it's driven by the client, how fast they're trying to move and how fast they can put things together, because I need all of their documentation, all of their incident reports, and everything else that they want me to look at. And before I even get on site, I interview a ton of people, right? From leadership to line staff. I do that all virtually so that when I get boots on the ground, I can focus on, getting out there. And while I'm walking around, I'm talking to staff, right? Informally. Hi, I'm Dave Corbin. I'm a consultant that's been hired by this hospital. What are your concerns around
That's
violence?
really
And
important.
that's huge. And that is, the
That's
interviews
where
are
I get the most valuable information.
exactly
Because we're
same
not
here.
reporting. My clinicians are not reporting. Nurses are not
Yeah.
reporting for a myriad of reasons. We could do a whole
Yeah.
podcast on that. But I think me walking around and just showing my support, I'm a nurse that's in this space. First of all, they think
Yeah.
it's cool. They're like,
Yeah.
wow, there's somebody doing something about this. So the
Yes.
hospital has invested in me, right?
Yeah.
Just by seeing your face there, they know that they're making an investment.
Yeah.
And then for me, I do, in the EP side, we call it an advance, right? So
Mhm.
you do that advance, because I don't do threat assessments. If I have to do a threat assessment, I'm a nurse. I know my lane and I stay in my lane, right? So I'll call you or I'll call Paul, and
Right.
we'll figure that out. But what I do like to do is develop the training based on the way the rooms are set out, based on
Yeah.
the unit. If you're doing a cover to cover training, they don't know what the layout of your facility is like. They don't know what the workflow of the nurses is like. And if you
Right.
can make that training incorporate into the workflow, it's easy to implement. And a lot of times
Yeah.
I have the opportunity, because we drip out our basic program online first. So it's like 15-minute modules. They take
Sure.
it, they learn what they need to learn. And then when we show up, it's just basically a sign off of the physical tactics if they're on that advanced echelon.
Uh-huh.
And when I go, I'm able to coach at the bedside a little bit. Like I can see, take me to who's the patient I need to, oh, Mel's here. You need to come see 306 right now. I'm like, okay. And I stand at the door and I'm like, all right, give me her meds. And I'm watching. And a lot of times I just let them kind of work it out, or I'll observe when there's a BERT team called. And then
Yeah.
I don't intervene unless I really feel like it's a safety issue, but I might coach a little bit. Like,
Yeah.
let's, get your, take a deep breath. She doesn't mean it. Like you're doing a great job. That's things like that. And I think those are really beneficial when I'm around looking at the space, because that's an important portion of training. What you do at an upper level, you have the ability to talk to the director of security for that location and get an idea of what's going on. So you can help navigate and help them come up with a plan for their locations.
Yeah, and it's incredible what you learn from staff, like just talking to them. And at one point, I wrote a LinkedIn post about this once, but I was in the emergency department at a very large hospital, and talking to two nurses, and another nurse comes over and she goes, she's like grunting. She's like, that patient in room 13 just kicked me in the stomach. I'm like, oh my God, are you okay? She's like, yeah, it just, shocked me. He's an elderly guy. And I'm like, okay, well, you should call security, right? No. I'm not going to report it. I'm like, what do you mean? I'm like, you might need medical treatment later. What if, you have bruising later or something? No. Nothing's going to happen. Nothing changes when we report something. And I'm like,
Yep.
there you
That's what
go.
it is.
So it's those insights. Your directors aren't going to tell you that. Managers are not going to tell you that. But this line staff are. And in another hospital, I had a nurse say, I'm like, you have any security concerns? And she said, yeah, you see that elevator over there? That allows anybody to come into the emergency department. Like, this is the treatment area. She's like, and there's no card access or anything. I'm like, what? And I go over, there's a card reader on it. I ask security, they're like, oh yeah, that card reader hasn't worked for like months. I'm like, you need to fix that.
Like,
That was one
thank
of those
you.
urgent notification things, because it's like, but it's like these things. And then the client will ask me, like, why aren't my staff reporting this? I'm like, because when they do report it, they feel like nothing changes, right? So if there's no follow-up, if nobody goes and investigates, if you report violence, or if you put in a work order saying that the cartridge is broken or the door doesn't shut, nothing happens, then guess what? Eventually you're going to stop, because with everything else you have to do, why would you waste your time doing
Right.
that?
What do you think from I obviously we know the reasons why they're not reporting. What are you seeing on the end when you say that to an organization, they're not getting what they need when they report? What are you usually met with, and then how do you kind of overcome those objections?
It's I mean, what I find, it's typically like a resource issue, right? They don't have, they bottleneck things, right? So they'll have like, oh, this certain person needs to be the one that follows up, right? The risk manager, or this, some high level person that's got a million other things to do. And,
Okay.
you know, security can start that process, right? At least have somebody come out and say, hey, I saw you put in a report. I wanted to follow up, right? That should be as soon as possible. I realize that the report might not be seen until the next day, right? Obviously, if it's an emergency, you hope that they call. But if it's the next day, like, assign somebody, a security officer, to just come down and get some more information. Hey, do you need some support, some safety planning? Are you worried about this patient? You know what I mean? That kind of stuff. And that can take the edge off right there, right?
For
Just knowing
sure.
that
And that's
somebody's paying attention.
that when we train security, so we either train healthcare workers or anybody that's in patient care areas or security, right? So that's one of the things that my co-founder, who was a Marine and does security and did EP, that's one of the things that he pushes when he's doing the training course. He's like, look, you aren't just a mall cop anymore. You're not
Yeah.
just standing there. Like, this is a high reliability organization, and you guys are expected to be professionals. When you're rounding, round frequently, and then when
Yeah.
you're rounding, do purposeful rounding. Like,
Yes.
hey, I'm here. If you haven't started the incident report, can I start one for you? And then we'll follow up, because
Yeah.
nurses are very busy and we're not going to stay after work to do these reports. So if security has the time, it is helpful for us to at least generate a report. But what I'm seeing is those two silos are different.
Yeah.
Like, security reports go to one place and
They do.
clinical reports go to another. And I think that's where, having the low cost training, we're able to leave that budget open for tech upgrades. So if you
Yeah.
want to bring in a tech solution that can help you better manage your reporting, and collaborate, there are things out there that exist. And, having the availability to bring in an expert like you to make the recommendations, and then kind of close that circle on
Yeah.
what are the things that we need to do and focus on. So if I hear at the bedside they're not doing anything with the reports, I may go to David and say, okay, David, I need you to talk to administration and come in and kind of help coach them on that side
Right.
about what they need to do. And then I might reach out to a tech partner and say, hey, I think they could be really useful in this situation. But because the training was cost effective,
Yeah.
then they have the budget to do the rest of the stuff. Because I was
That's it.
hearing when I first started this, they say, oh, next year we'll have to do that,
Yeah.
or things like that. So I think what you're doing with the book and having a strategic plan, like, if I was a CNO and I was looking at your book, what I would do would be go through the book strategically,
Hmm.
read a section, and then find out what my hospital's policies and procedures are that relate to that
Yeah.
section. And if I don't have a policy and procedure on it, then reach out to you or somebody else, to see where we could get something like that from. Because ultimately, there's been a lot of influence and increase in litigation from nurses, because right now the mandatory requirement is a click through safety PowerPoint.
Hmm.
And if I was just beaten with a metal mop, and the last time that I took my click through safety PowerPoint was a year ago, and I guarantee you that my lawyer is going to jump on that. Like,
Oh
you
yeah.
did not provide adequate training for her when she was telling you that every day this is a problem.
Let's check the
And I
box training.
Yeah, and I
It's not
think
real.
hospitals are going to find that, they can't hire their inside counsel to represent them in these situations. They have to hire outside counsel for this.
Yeah.
So it's very expensive, and the
Oh
cost
yeah.
of bringing even you, me, and a tech company in is cheaper than bringing outside litigation for something like
Yeah.
this.
100%. Yeah. And those Somebody was just telling me the other day, it wasn't for a safety training, but they said that they got assigned all these trainings, on the online platform, and they were like, some of them were long and some of them were click through, and I was going tick 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 tick. You know what I mean? You
I
can
open up
tell the
all
ones
the
that don't have
windows.
any restrictions because they're just bang 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 bang. How fast can I get to the end of this? And
I
hopefully,
open up all the windows and let them all play at the same time. And then and then the nurses take pictures of the
that's
answers
genius,
and
by
then
the way. Never
text
thought
each
of that.
other we
Yeah.
all text the answers to each other. And then we usually get the one new nurse that's really smart to take all of our tests for us. And then we
Oh
pass their
my god,
meds. So
that's sick. I
that's
remember I
what's
used to get
really
hung up. I used to get hung up on this back safety training every year. I was like, they were just
it's
like,
so
I don't
hard.
need to
You're like, oh,
know.
I'm on the backstage, the ergonomics training. Can you please, what was the right answer? And you're calling everybody trying to figure, did
Yeah.
you pass this shit?
I don't need to know like what the C14 part of the spine is for. Like, I don't know if there is a C14, but they would ask questions like, what are these parts of the
There's
spinal
not.
column for? It's like,
There's only 6 C's, but
okay,
okay.
so but if you
C7.
have a 14th, then maybe you have a medical problem, right? Maybe you're
Yeah,
really
your
extra
neck
tall,
is very long
super
at
tall.
that point.
So yeah, clearly I should stay in my lane, right? But with the back safety thing, I was just like, how much information do I really need to know? I just need to know how not to hurt myself, right? And that kind of goes back to what you're talking about with the security training. Like if you go through, and there's lots of great programs out there for de-escalation and hands-on stuff. But I love your approach because you're doing it at the bedside and you're telling people how to incorporate it, right? Because if you go into a typical training, what's happening is that you're getting all of the techniques, right? Especially if you're direct care, you're going to get all the techniques, all the physical stuff, right? Depending on how far they go. But a lot of that, those folks are never going to use, even if you work in the emergency department, right? So what you're doing is that you're making it relevant to the role, right? It's coming from somebody who's doing the work, right? Knows what works, knows what doesn't, can speak the language, right? The right language so that it aligns. And I like what you said about it aligning with the workflow. None of these other programs have any alignment with workflow. And I think that's one of the biggest issues is like, how do you make sure that when you enter a patient's room, like you're thinking about A, B, and C, right? Whatever you have to do clinically in there. But how do you incorporate just one additional element to say, just pause before you enter that room and get a look at the scene, right? Because if the patient's sitting there like this with their fist clenched, hey, maybe I should ask a colleague to come in with me, or maybe I should ask them from the doorway, what's going on? Are you feeling okay? And I think being able to incorporate that would help them to hold on to it, right? Versus you just went through 8 hours of training in one day and you've covered everything from how to talk somebody down who's anxious all the way through, a prone, direct to prone
Don't talk
takedown.
about the prone holding because it makes me nervous, okay? I'm from Baltimore City, okay? And you do not hold patients in the prone. If your security option is teaching you to hold patients face down, as a nurse, I cannot assess their airway and I cannot assess circulation that way. No
Yeah.
one should ever be held
Mm-hmm.
on their tummy. And I think that's one of the things, like some of the other training programs are out there, they're using these older techniques. When we in
Yeah.
the 80s and 90s as cops, you're a cop, you're trying to protect yourself, the person may have a weapon. Like it's a much different situation than what we're doing at the bedside. And I think that there needs to be a different approach. And I like what you said because it's very true. If I sit through an 8-hour class, first of all, that's hella expensive to train every
Yes.
employee for 8 hours.
I've
That's why
seen it.
we do the train the trainer model where it's like
Yep.
25 employees, we get them very well trained we do a 4-hour class, and then the next 4-hour class is they're teaching the class to me. And I'm going to give them every objection. I'm going to give them every possible salty ass ICU nurse.
You're
I
gonna
don't
be that
care
nurse. That is
what.
awesome that you do that.
I'm
Yeah.
ratchet, okay? I am ratchet. And they have to navigate around me. And then once they can prove that they can do that, they pass and then they move on. But nurses are already dealing with the violence. So to expect them to start from zero and be
Yeah.
delivered by someone who's never even had to wipe an ass before, that is a totally different skill set, like
Yeah.
they don't
Yeah.
understand. And so when we deliver the training like that, it allows people to have the most important thing that I think that we teach is emotional regulation.
Yeah.
But you can't do that from a what could you have done differently this time?
Oh no,
You
don't
know,
even do it.
it's
Yeah.
it's a dude, this sucks. Like I'm sorry that that happened to you and it's not okay, but you choose how you respond and the
Right.
organization has to have the policy and procedure to back up the nurse
Yes.
when the nurse says, I noticed, I went in the room, the blanket was over the head. I asked them to please remove the blanket so I could assess them and they didn't. That's obstruction. That's not normal. Unless it's a 14-year-old girl on her period, that's not normal. Eye rolling is not normal. Throwing things is not normal. So those are three behavioral anomalies and I should be supported by the organization to say, I chose to back out of that room and only provide life-saving care. If a person is
100%.
dying, they're not going to assault me. I
No.
promise they're not going to if they're dead, but I can provide the care that's needed, I have this
Yeah.
shirt as an ICU nurse. It says deader the better
What is
because
it?
it says deader the better because I like to be busy and run all those pumps and that's a fun day for
Yeah.
me, right? Like that's good. If I can keep you almost from death all day long, that's a
Yeah.
beautiful day for an experienced ICU nurse. So I but there is I might be coming from that room and going into the next room where it's a disrespectful frequent flyer who, is there because they know if they say they have chest pain, they immediately get a spot in the hospital. So I
Yeah.
have to be able to learn how to navigate and approach that person with the same empathy that I'm going to approach the person that's dying with.
Yeah.
And I think that's a key element of what we teach. And we teach professionalism. How
Yeah.
can I just maintain my role as a nurse and educate the patient as much as possible to avoid the violence? And I think that the collaboration between what you're doing, what I'm doing, what tech people are doing is what's going to solve the problems that we're having. We can't do this in silos anymore. And I think it's
No.
becoming very apparent that we need to bridge the gap, but we're focusing on the wrong things. We're focusing on
Yeah.
legislation. We're focusing on OSHA. We're focusing on what the Joint Commission wants. We
Hmm.
need to focus on what the clinician is saying and what the
Yeah.
experts like yourself are saying that we need. And then that's where we need to spend our time and resources.
Right. No,
So,
I
but it is,
agree. And
I think it's awesome what you're doing. How can people get in touch with you if they want to have your consulting services or read your book?
the best way, well, my book is available on Amazon.
It's good. You have to read it. It's
Like,
cost effective. It is wonderful. It is a must have. We have one right in our office here and we got the digital version and then I went ahead and I was like, "Oh, let me order the actual
thank you.
book cuz it's good."
Thank you. Yeah. And that the name of the book is Patient Violence Prevention and Mitigation.
Yeah.
I mean, the long name is, healthcare security field manual, and then that name. But
I
patient
love the
violence
field
prevention and
manual.
mitigation, you will find it. Also, it's available internationally, so wherever you are, you can order it. And I also noticed it's available through like Barnes and Noble and stuff like that too, because of Amazon's expanded distribution program. So I do
Look
have
at
another
you. You
book.
got to go take your selfie at Barnes and Noble and then
Yeah, no, I don't think it's on a shelf though. I think it's like,
we're going to get
ready
you
to
there.
print. That would be cool if it was on the shelf. Um, but then
I'll
there,
just go and get a copy. I'll take my copy to Barnes and Noble with my coffee and I'll take a
yeah,
picture of
thank
you.
you. I would appreciate that and pretend you bought it there. That would be great. Uh, I'll take what I can get. I'm also working on my second field manual, which every time I decide to write one of these, I'm like, I can get this done in a few months. And I'm like in the weeds for like, I don't know, 9 months. So this one is called ambulatory site
Ooh.
security, but I need to change the name, and I need, maybe you can help me, not right now, but I need some help because I feel like it doesn't cover ambulatory site security doesn't cover what the book, because it gets into workplace violence specific to the ambulatory, care environment, and like even security operations. It's kind of like that name is too narrow, but I also don't want it to be like a, super
Hmm.
long name that
Let me
nobody
take.
can
I'll
remember.
think about it because I'm pretty
Yeah.
good at and so is Dela Cruz. So we'll think about something for you. But
Okay. All right.
it's been an
I'll give you
absolute
credit. I'll give
pleasure.
you
It's
props in the book if you come up with a good name. How's
perfect. I'll write you a little note. Like, I love this. You should read it.
that?
I think that what you're doing is incredible. Thank you so much for doing everything that you're doing to protect myself and my colleagues. And I'm just happy to be able to amplify your voice. The point of Tactical Scrubs was allowing nurses to understand who's out there advocating for them on the healthcare side, and allowing organizations, especially those clinical leaders that are now tasked with creating workplace violence programs, to know what's available to them and to reach out. So please, if you would like to connect with David, I'm happy to make an introduction to you on LinkedIn,
Thank you.
or via email. You can send me an email at melcortez@cortexgold.com. And you can also reach David. What's your website, David?
It's dynamicsecuritystrategies.com.
Okay. And we'll put all
Yes,
this
I
down.
probably could have found a shorter name, but that's the best I could
I
do.
like it. It's perfect because dynamic, it needs to move, it needs to
Yeah.
flex. It's exactly what you talked about, and it's right on brand. And I think it's going to be the future of how we deal with all this. And
Thank
I
you.
thank you for your years of dedicated service to us. And I'm
Thanks,
looking
Mel.
forward to reading this next version that you put out. And we will chat again soon.
Sounds good. Thank you so much for having me, Mel.
You're
Appreciate it.
welcome.